with Vincent Planche in German neurology. We had concern that anti-amyloid immunotherapy are not really disease modifiers, but could be effective as symptomatic therapies. So we advocated for a change in the clinical trial design to demonstrate that what we really observe in this trial is disease modification and not a simple symptomatic effect. Why is that question important? Because we are targeting individuals at the beginning of Alzheimer's disease, beginning of their symptoms with prodromal stages, and we treat them for 18 months while the disease will keep evolving for 10 years. So we don't know if the effect we see at the end of this 18 months will keep increasing, will stabilize, or will disappear after this 18 months. So I think it's a crucial question, since unfortunately the magnitude of the effect of this drug is quite small for the moment. So as it is quite small, it has a small effect, and as it has also side effects with edema and hemorrhages of the brain named ARIA, with a significant proportion, as well as very serious cases and deaths. I think we have, it's my opinion at least, that we have a drug with a questionable benefit-risk ratio for the moment. That's why we advocated for a clear demonstration of disease modification, because in that case, this would mean that the effect will be an endure effect over time or may increase over time. So the benefit-risk ratio after 5-10 years of treatment will be much better than what we see now with 18 months. But this needs to be demonstrated, and with the current evidence we have, one could argue that these drugs are disease modifier, but another one could also argue that these drugs are not disease modifiers. So we have both arguments at the moment, and we cannot be sure of one of them. So we need new design, innovative design for a future clinical trial using this drug for this specific population at the early stage of symptomatic Alzheimer's disease. So there are two sides of a coin in the new design we propose in this paper. The first one is to use biomarkers, because we all know that biomarkers can reflect the downstream pathology of the amyloid antibodies. So showing that an anti-amyloid antibody would reduce the tau pathology load in the brain as measured with tau PET, and then the neurodegeneration as measured with MRI atrophy, and then in turn the cognition. This would be one of the arguments to demonstrate that we have a clear disease modification. So we have drug with an effect of amyloid load, PET load, MRI atrophy, and then cognition. So we need to implement as a predefined primary endpoint, as a co-primary endpoint. We need to add this kind of mediation analysis. So from the drug effect to the cognition effect, using all these biomarkers to correctly demonstrate that they have a disease-modifying effect. But this is not all. We also need to implement innovative design, like delayed start designs, where some individuals will have an early start, a long trial under the drug, while others will have a delayed start. They will start on the placebo and then start the drug a bit later, and we'll see if the curves join or if they stay apart during the whole trial. This kind of design allows us to say, okay, that's a symptomatic effect, because whenever we start, whatever the stage of the disease, when you start this medication, at some point the patient will turn out to be the same. It would be in favor of a symptomatic effect. On the other hand, if the curves can never join, then it's in favor of a disease-modifying effect. But there is no absolute answer. Is the drug a disease modifier? Is the drug a symptomatic drug? And the drug may have also both effects, symptomatic and disease modifying. So we need a set of arguments to demonstrate that, the delayed start design and the mediation analysis based on biomarkers.